Thank you to the organisers for inviting me to speak today on breastfeeding and HIV. Here are my disclosures and conflicts. Decision-making about breastfeeding in the context of HIV is really complex. There are many things that a birthing parent and a healthcare provider need to consider, both emotional and medical. And if we think first about bonding between a birthing parent and a baby, well, this is really where the pressure starts, because parents want to be the best that they can be, but already they are being told that breastfed mothers are closer to their babies than mothers who bottle feed, and that long term there can be social and behavioral implications for babies who are not breastfed. But data is actually conflicting on this, and this is data I found looking at an association between breastfeeding and low mood and bonding difficulties versus mothers who never breastfed or who had stopped breastfeeding. Now, the researchers weren't able to say why this was, but they were testing the hypothesis that bonding and breastfeeding are really important and are the only possible outcome. And they've shown that actually it can be quite a negative experience. And yet people are not told this when trying to make their decisions. So what about breast is best? Is it really? Well, we are told that breast is best, so birthing parents are told to be ready with a socially acceptable justification as to why they aren't doing the best for their baby. So they're told to say their milk isn't coming down, that the baby is not able to suck properly or latch on properly, or perhaps they have painful nipples or breasts that are causing inflammation, and they need to take antibiotics, perhaps, that they don't want to give to the baby, or for personal reasons, they have decided to share feeding with the other parent. So there are nighttime feeding duties that can be shared between the two. And so breast is best has always been thought to apply to women only who are HIV negative, whereas in fact, we're starting to see some data that perhaps in the context of HIV, there could be a positive outcome. So this was data presented at CROI by Kuhn et al., looking at babies who had acquired HIV in utero and who were given early ART and breastfed to look at gut microbiome. Now, why is this important? We know that gut microbiome long-term, if there are a high number of organisms and great variability, is better for long-term health. And this study showed that where babies were given both early ART and breastfeeding, gut microbiome was much more florid and variable, and therefore this is thought to be a positive. So the breast is best could also apply in the context of HIV. So what about ART, adherence and toxicity? So we first knew that breastfeeding and HIV was an issue in 1992, when there was an increased transmission risk of 14% reported in Nigeria. In 1999, it was thought that perhaps exclusive breastfeeding might be safer, but in 2001, it was decided actually no, formula feeding was the safest thing to be recommended for birthing parents with HIV. This continued in 2005. However, in 2008, WHO revised their advice to recommend breastfeeding first line following excess morbidity and mortality in babies born to mothers living with HIV. And this was data that was reported by Tracy Deeks et al. At CROI in 2007. So where we want to do no harm, what have our guidelines said? Well, in 2010, the British HIV Association, BIVA, of which I am part, released a statement on women breastfeeding when the viral load is undetectable. And this was the first group to suggest that if where a woman was undetectable and staying on treatment and adherence was known to be good, she could be supported to breastfeed and not be reported to social care, which is what historically would have happened. This did not apply in the context of women who weren't taking treatment or who had a detectable viral load. So in 2012, this statement was incorporated in the BIVA guidelines. So women with an undetectable viral load who choose to breastfeed exclusively for a maximum of 6 months could be supported. In 2016, however, most guidelines were still not recommending or supportive of breastfeeding. However, in 2017, this changed. EACS updated their guidelines to allow breastfeeding if a woman insists. Interesting choice of language. In 2018, US guidelines changed to give evidence-based information and to support choice for women living with HIV, and BIVA guidelines continued to support women and birthing parents. In 2022, however, no guideline recommends breastfeeding first line. And this is because we can't really shift the risk to zero. So if we want to use drugs in clinical trial in the context of breastfeeding and HIV, getting ethical approval is going to be difficult. Insurance cost setups are going to be very, very high and can be very off-putting for pharma. However, in this context, women and babies can be followed very closely. Small numbers will probably be recruited to studies initially with regular safety assessments and protocol-specified safety endpoints. So it could be a really safe environment to look for data. However, the risk is that the new drug could be ineffective and the new drug could be toxic to a baby being breastfed. So what if you do it outside the context of the clinical trial? So in this context, birthing parents and women do not have access to newer drugs being used in clinical trials. If there are problems or safety signals, well, they're not going to be picked up necessarily in a standardized way or reported in a standardized way, and information may not be shared quickly enough to realize that there is a problem with the drug. But also, women and birthing parents have to choose without an evidence base. So the risk here is that birthing parents with HIV are using older, ineffective drugs. There's a risk of harm potentially to their HIV. So it's not ethical either. And the concern has always been that in the context of breastfeeding, women taking ART may be passing on drugs that are toxic to their infants. And in fact, we haven't seen this come out. And even data this year from CROI that was presented was looking at women who were breastfeeding babies on TDF-based ART where they had not had it during pregnancy. And they compared this where infants were receiving nevirapine to give them PEP during the breastfeeding period. And they looked for abnormalities in infants' bone and kidney outcome. And what they found was actually there was no signal that was clinically significant in either bone or renal abnormality, or in renal function. So again, we're not seeing the safety signals that we keep looking for. But the risk isn't zero. And although we've all been reassured by data saying U equals U from partner study and various other studies for sexual transmission, this does not apply in the context of pregnancy and breastfeeding. So what data do we have? Well, the earliest data that we have in the CART era came from BAN, Mabana, and Keisha-Bora, where the risk was thought to be 1 to 5%. But still in high income countries where there is access to formula feed, the risk is 0, therefore breastfeeding continued to be avoided and formula feeding recommended. However, newer data from lower middle income countries, so from BISPO and PROMISE, suggest that actually the risk is even lower. So at 6 months, it's 0.3% from the PROMISE study, and at 12 months, it's 0.6%. So that risk is really, really low. And although there's still a very small risk at 12 months, it's a doubling from 6 months. Therefore, this is where the 6-month cutoff comes from. And what about exclusive versus mixed feeding? Well, actually, most of this data comes from the pre-CART era, where we know that having a detectable viral load or advanced maternal HIV increases the risk of transmission from breast milk. Also, longer duration of breastfeeding, nipple inflammation or infection, or baby mouth or gut infection or inflammation also increase the risk of HIV being transmitted. However, really the biggest problem is not mixing breast milk with formula milk. It's actually if you introduce solids too early. So data suggests if you introduce solids, particularly in infants who are less than 2 months of age, the risk of transmission significantly increases in a breastfed baby. But we don't know whether or not all the data that we have still applies in the current era where we have really good HIV treatment for birthing parents. And whether or not people decide to breastfeed, if they decide not to, we offer cabergoline, which can be given within 24 hours of delivery. We discussed it at a previous seminar a number of years ago, but this removes the ability to breastfeed. So people need to be really sure of their decision. So what's happening in the UK? Well, we have been collecting data on our national database, ISOS, previously NSHPC, and women have been breastfeeding according to the BREVA guidelines and supported where they have been undetectable. So of 9,000 births from 2012 to 2020, we have seen 150 women who have breastfed their babies. We still have a bit of reporting delays. We know we followed these babies out to 20 to 24 months, but as yet we have not seen a single baby become HIV positive. And in fact, during this time, our vertical transmission rate by year of birth at 2-year intervals has fallen consistently, and we are now at our lowest transmission rate ever of 0.22, despite women breastfeeding their babies. And why are people choosing to breastfeed their babies? Well, it doesn't matter whether they're diagnosed before or during the pregnancy, the reasons tend to be the same. Bonding is really the key. Health benefits are also really important. So the breast is best, the bonding, it's really there. But also family and friends' expectations and pressure are significant. And in some cultures, not breastfeeding can be a neon sign for disclosure of HIV. Some women have breastfed previously before their diagnosis or since their diagnosis and are very confident to breastfeed. But newly in the UK, we have started to see concerns about finance of breastfeeding being the cheapest way to feed an infant, particularly if there are other, if there are more family members. And this is a problem. I think it's going to be a growing problem in the UK. And these issues about disclosure and cultural intersection about having to breastfeed and it being seen as culturally acceptable will significantly impact a woman's decision. And the Pacify study, which is a UK survey of women living with HIV, we had 94 birthing parents responding to the survey, over a third of whom wanted to breastfeed, but 2/3 had to invent a reason as to why they weren't breastfeeding because they were being asked directly by family or even community members as to why they weren't breastfeeding. And there still remain concerns about passing on HIV or ART side effects in infants. So there really is an information gap here that needs to be closed. In Germany, so Lila Haberl presented at this conference 2 years ago, the Not Recommended But Done survey, the LN retrospective analysis of breastfeeding among women living with HIV in Germany. So 42 women from 20 centres, median age of 33, majority of whom were born abroad and had HIV diagnosed before pregnancy. They had a median duration of breastfeeding for 20 weeks. So within guidelines, one woman breastfed for 104 weeks. All were undetectable. 2 had blips whilst breastfeeding. They were under extra follow-up and they stopped. But of note, neonatal PrEP use was variable. And yet there were no infant transmissions. So we've had 2 studies, so UK and Germany, no transmissions. And why do women want to breastfeed in Germany? Well, because if we look at the blue box, we can see breastfeeding is something extremely practical, exhausting, and beautiful. And then in grey, the thought of not using my breast milk made me feel very sad. It seemed a waste of a precious resource. So all of these things are really important to discuss. And we're trying in the UK to get more information about decision-making, both from women and healthcare providers from the Nourish UK study led by Bakita Kazada. So watch this space for more data. Peer mentoring is key. And birthing parents would say to another birthing parent, start your research early because you're going to need to think about the decision. Find a support group. But really the key is you are not alone at all. And I think that's very powerful because this is a huge decision to make. So in summary, decisions regarding breastfeeding are complex for birthing parents living with HIV. And there is a growing evidence base, both qualitative and quantitative. But as yet, we have many unanswered questions in the era of good HIV treatment. U equals Y, U does not apply, and guidelines and recommendations are not yet consistent. An early informed discussion with healthcare provider and a peer is really key. And I would like to thank women and birthing parents living with HIV who are pushing the boundaries here and making us get more data, particularly the women from my clinic who I've supported to breastfeed, who make me feel more confident in supporting other women to breastfeed. Also ISOS and BIVA for information and discussions about breastfeeding, Professor Katrina Waite for her help with slides. And I would like to dedicate this talk to my colleague, Dr. Marta Vasiliev, who's my vice chair of WAVE, who's based in Lviv in Ukraine. Thank you very much for listening.